Me loud and clear. If you could type it in your chat box. So far, the audio is great, and thank you very much for being prompt and meeting. So, again, afternoon from the Philippines, and good day to everyone. This is Aliyah Evangelista for eHealth Information Network. Welcome to this month's AeHIN Hour, our online learner sharing session that happens every second Wednesday and fourth Fridays of the month, 3 p.m. Philippine time. Broadcasting from the National Health Center in Manila, Philippines. Today, 3 o'clock p.m., and very happy to have with us today Heavy as our speaker on topic Clinician Led eHealth records on approach sharing of health information. Some questions before we start our session. We're now this WebEx as platform for this meeting. If you encounter problems in your connection, please log the session and join the meeting room immediately. You're muted during the meeting, and if you have questions, you can type it in the chat box located on the right panel of your screen. Click the hand button if you want to raise your questions directly to our speaker. And on the moderator signal, I can unmute you. You can add your question to the speaker. But having a small crowd now, I highly encourage everyone to raise them directly to our speaker so we would have a more fruitful discussion on our topic, most especially on OpenEHR. At meeting, do not forget to accomplish the evaluation survey of this AeHIN Hour, and once you completed it, we send you more information, reading, and other resources on our topic today. And lastly, stand by for a photo staging session so we document your virtual presence in this AeHIN Hour. Basically, what we will do is we will open our webcam, and I will just have a screenshot of those who are in our meeting. If you're ready to participate, let's start the session by knowing more of our speakers. Our speaker this afternoon, Heather Leslie, has over 15 years of experience as a hospital clinician and family medicine. She has in high-level health IT strategy development in Australia for the last years and has taken a hands-on role in creating software applications for use by primary care clinicians and consumers. Her expertise deal on developing personal health records, supporting consumers to take on the role in healthcare and in support of self-management. Currently, she is Director of Clinical Modeling at OceanInformatics and Clinical Program Lead at OpenEHR Foundation. Please welcome our speaker for afternoon, Heather.
Thank you. Be here. Thank you very much for inviting me. Can you hear me clearly?
Yeah, and very clearly.
It's an honour to be invited to speak to you. This is something that I'm very passionate about and is something that's certainly gaining some traction internationally. So it's something that I'm very excited to be able to share. Introduce me. I'm a clinician. I have started my professional life as a primary care physician, and in the last must be 17 years I've been working in informatics, and the last 8 years has been involved in this side of things. It's about getting health data into good shape to be able to start to share, and that's I guess where my everyday work is at the moment, and certainly something that is getting some excitement around the world in some of the sort of methodology that we've been developing, and that's what I'd like to share with you. Kick off here. I just want to move now. There we go. So to sort of set this a little bit, this was an article that I found in Forbes magazine just at the end of April. I sent all the slides to Alia so that you'll be able to get a copy of these, and you'll get this link in there as well if you want to. But it's discussing about big data, heading towards that peak in the Gartner hype cycle, but it's also mentioning about how difficult the little data is. Yes, this is my world at the moment. It's about the little data. The little data in healthcare continues to give us peptic ulcers. I found that quite an amusing statement. It goes on, there's a few quotes here that I just thought were really interesting about clinical data at the unit level being chaotic and dysfunctional, how it's difficult to transfer, it's difficult to use, etc. And it's also about the opportunity, that last line about technology vendors to lock in providers. And the statement, I guess, that's even most telling, I guess, from my point of view, is about this reliance on software vendors to hold on to that format of the data itself. And that's led to so many problems. We've had electronic health records, for 20, sometimes even, some people 30 years. We've had health records in computerized format for this time, and we've still got this perpetual problem of how to share health information. And some of the problems really that are contributing to this is about the fact that we've got this vendor or application dependent data. And that's, I guess, some of the message that I'm trying to give today is that we need to look at the data differently. But I guess that's a good starting point for today's presentation. Why health information so difficult? Read it probably many times. If the banks can share information, why can't health? And there are lots of reasons, and we all know it. There's lots more than this list. But I guess three at the top there are the ones that I'm wanting to focus on today, and wanting to just point out that the data that's important. If we get the data right, that a lot of these problems start to go away, and it contributes to actually solving some of the issues around interoperability. So this is what my message is going to be about. It's about the data. So if we think of the complexity of clinical knowledge, SNOMED is big and broad and deep, it's complex, it's open-ended, and it's also dynamic. So we haven't got just something, not building a tax database where we've got levels of tax that might change once or twice a year. We've got something that's pretty dynamic and changing, and it's growing all the time. So this is not something that is a typical domain problem that we have to solve. Health is quite different. And for clinicians who are watching, if you think around something just like medication timing, and you can look at this list, it makes sense to most people. I'm going to take a medication every 4 hours or 3 times a day or something. These all make good sense. But the problem is it's not this simple, because there's also these examples. And again, it makes sense to the clinicians and consumers. And these ones. These are all the kinds of ways that clinicians are wanting to be able to record about the timing of how a medication should be given. There's no systems in Australia that have got that capability to manage that level of detail, and yet this is the way clinicians operate. At the same time, no clinician works the same way, and I'm sure that this is something that you're coming up against all the time. Some clinicians want to work in free text, some want to work with structured data, they want to be able to do decision support, so they need structured data, but they also want to be able to some of the subtle nuances of a clinical consultation. It needs free text. There's lots of ways that people work differently. We want graphs, we want questionnaires, we want diagrams, we want ECG waves, we want all sorts of things from devices. We also know that medicine is fractal, so that when examination in a health record, we might want to start looking at a limb, then actually narrow down to a part of the limb, to maybe a digit in the hand, and maybe then on down into a lesion or a cut on that hand. And we need to be able to get down to increasingly fractal levels of detail potentially. And we also know that one clinician and another will work differently. So I've had obstetricians who've said to me, we won't be able to share the same record as a midwife because we work quite differently. Well, in fact, it's not quite true. The actual underlying data is largely in common, but they might use slightly different terms for some things, and they might use slightly different levels of detail. But largely the data can be common. So there is this myth that one size fits all, and there is this myth that different clinicians work the same way. We need to be able to manage this clinical diversity. So how do we do that? And that's part of the challenge that we've been addressing in the last few years. We also think about the way clinical information systems have been built over the years. The traditional way is for some the engineers, the techies, to come along to the clinicians and to ask them specific questions. The clinicians answer as best they can without understanding the sort of technical stuff underlying it. And then the techies go away and they convert that into a structured relational database that's locked down. And when that product goes to market, then everything works quite nicely. But as soon as something changes, then you start to get the mismatch happening. And so then the engineers have to start managing the database, they have to start changing it, adding tables, etc. And gradually over time the integrity of the database can start to diminish, the quality diminishes, and you have to then port the information through to the next system. And in fact, this is a diagram from one of our clients in the Netherlands who described what happens in his hospital information system, that every 7 to 10 years they have to convert all of their data through to the next health information system. This is an ongoing issue when you've got lock-in into proprietary databases, and that data needs to be transformed each time into the next vendor system or the next technical transformation that needs to be managed, the next of the software, etc. The problem with that obviously is data loss and transformations, so errors creeping in, etc. And you never got quite what you sort of started with. There's always a risk with all of that kind of thing. So we need to change that kind of dynamic. There's all this notion of these bubbles. Now they could be either organisation-centric or they could be gender-centric. And the fact that this is from Canada Infoway, it was a consumer information video, and they were trying to sort of promote getting involved and getting their health records. Those little x-rays and things were bouncing off the edges of the bubbles and so on, but they weren't obviously able to share very easily. And what we tend to do is we tend to build messages that allow those bits of information to be shared. That's the traditional way of doing it. They're all HL72 messages or CDA messages more recently, but those sorts of messages or document-based systems need to be negotiated and can take anything up to a couple of years for standards-based messages to be negotiated, agreed and published inside the standards world, certainly. So this is an incremental evolution, this that we've been doing for the last 20 or 30 years, and you just wonder how sustainable that is. We're locked into various documents or messages that are being sent between systems, but there's an awful lot of health information that don't fit within those messages or documents at the moment. And so they're either locked in or we have to build messages and negotiate each of those point-to-point solutions. And you just wonder if that's at all sustainable. I don't think it is. So a solution is where you have data that's independent of any technology platform or any application itself, and that's the key thing. That's obviously quite orthogonal to what's currently done at the moment. This notion of the potential for a universal health record, where the health record is the data, in thinking of it as an application or an electronic health record. And certainly in the US, everything is very much health record, EHR, EMR related. They can't think of it in other terms. Australia is starting to think a little bit differently. Europe is thinking a little bit differently in terms of archetype data and so on, but still, actually, that's the broadly held opinion and the point of view of new developments, etc. This lifelong health information hasn't been achievable because the technology platforms and so on, you need to be porting it between systems and you lose data and everything's very fragmented. So we've never had opportunity. But that's something where cradle to grave information, if it was done in an open and structured way that's transparent, then the potential for that to be carried through is also very important. The fact it might be independent of any specific message or document is very important. We allow the clinical diversity to shine. We allow dynamic knowledge change to occur, and we cater for that and allow that to happen. It's that data liquidity and exchange. It enables reuse of health information. It's multilingual, so it crosses all the international borders, and it's terminology agnostic, so it doesn't matter which term sets and things you use, we can start to have health information that can be shared. So the key things from my point of view, and that really leads into, I guess, where I think OpenEHR starts to provide some of those solutions. Is there anyone who's got any questions?
Heather, I hope you could also give us an overview on the OpenEHR, as Dr. Alvin Marcelo, our chair, shared. OpenEHR where he bridges the clinical and technical aspects of health information. Maybe introduction to the next slide.
Right. I will go into a little bit more. I'm going to be talking about the clinical knowledge side of things, but I will show you a diagram that shows that there is a full electronic health record architecture specification that also sits behind it. So the knowledge side of OpenEHR is around starting to look at this orthogonal approach. It's really taking this longer-term viewpoint. It's not just looking at what we do in applications now and message-based things that we just do to solve specific issues. It's looking at how can we take a long-term view that means that our electronic health records become lifelong data, basically. And start with this notion of a standardized clinical content definition. And if we reference model to that, we can turn it into a computable data definition or a data model. And if you do have that at the center of any of this kind of work that you do, they can be using that kind of thing for any of these particular purposes. Not just going to start with messages, so it's not just like HL7 is really largely based around messaging and that's it. We're starting at a foundational level of building blocks of these data definitions or models that then become the basis of all of these sorts of things. And messages is just one of those kinds of outputs. So it can be that we use them as a basis for decision support or for user interfaces or for semantic queries, displays, etc. If we start thinking in those sorts of terms, these knowledge models become agents for change and do require people to start thinking differently. We have to kind of step back from this sort of rush into let's build an application and say what are the kinds of things that we're going to need. So it requires a bit of upfront planning, and above all it needs clinicians. It needs clinician engagement. It needs clinician leadership to make sure that any of the models that we're building are the right kind of models, they've got the right content in them, that they're fit for purpose and for use, and should actually, I think, be part of the remit for some of the professional clinical colleges. They've got responsibility for a lot of our paper records, but a lot of clinical colleges these days don't know quite how to engage with electronic health records, and I think this is somewhere where they could actually get very actively involved, and that would be very valuable. The other things around semantic interoperability is the notion that we not only need messages for this level 4 interoperability, which we can achieve, but also the standardized content, and this is the notion of these standardized clinical models. In the OpenEHR world, these models are described as archetypes and templates. So these are the two things that you're going to hear a lot about during this particular session. And these archetypes and templates that then become the key for developing all of these downstream artefacts. That's the key thing. You'll get quite a lot about the archetypes and templates at the end of this session. Slides aren't progressing. Here we go. This is what Alvin was before. This is, in fact, a diagram of the full OpenEHR reference model. Now, the OpenEHR specification is a full electronic health record architecture specification. It's open source. It's built by the OpenEHR Foundation. And it's got a large technical component, obviously, and as a clinician, I don't have a lot of knowledge about all of this side of things. I just know that all these things are here. What I'm going to be talking to you about is around this, which is about the knowledge management side of things. It's about the archetypes, the archetype object model, the template object model that underpin it. And again, I understand the technical side of it as a clinician. I don't need to, but this is what's underpinning the archetypes and the templates. So it's one key component within something that is a fuller specification that allows a generic electronic health record to be managed from right down from data types and acts and so on, right through to the full electronic health record extract, etc. So for those of you who are technical, you'll know more about that than I will, but understand that there's a lot more complexity to it and a lot more knowledge that needs to underpin it rather than just the knowledge side of things. But the clinicians can engage in this little small pocket, and this is where they are absolutely integral to it, because the technical people really can't and shouldn't be involved in this side of things. Another slide that's not particular, but it just helps to give that perspective, Down the bottom, we've got this diagram again, which is all around the data representation and the basic building blocks that you need. Then we've got the archetypes that sit on that, so theme-based models around content, and multiple archetypes make up these things called templates, and the templates are used as the basis for things like the user interface, for forms, for messages and documents and so on. So think in layers. Here are very base building blocks from the reference model. Then we have archetypes as the content building blocks. The templates are used for the use cases and the documents, etc. And here's what the screens are actually built on. So multiple layers to this story. And I'm again going to be focusing on these two middle ones, these ones here. These foundation building blocks. It's a structured and computable specification about one discrete single clinical concept. So think of it in terms of as a clinical definition that's computable for something like blood pressure, for pulse, for height and weight, for a medication order, for a diagnosis, those sorts of things. Those as a single discrete clinical concept. And for each of those, we try to define a maximal data set. So we're thinking about all of the data elements that might be used to describe that single concept. And we try to the universal use case example. So we don't want it for just primary care. We actually want that single archetype to embrace all of the data elements that might be used, for example, in the case of blood pressure, from the blood pressure machine that you use in the morning in the bathroom to take your blood pressure for a personal health record or one of your devices, through to primary care, to an emergency team at a car accident by the side of the road, taking someone's radial pulse with their blood pressure with their radial pulse, through to the intensive care where you've got the machine that goes beep every 5 minutes, right through to population health and so on. So all those use cases, we want to know what are all the data elements and requirements that would they use in each of those scenarios to be able to record anything about blood pressure. And the basis for each archetype. That's the ideal intent, if you like. Sometimes we're a bit more pragmatic, but that's certainly the kind of notion that we're aiming for. It's not talking about minimal data sets, which is quite different to the way that we've traditionally come from, everyone trying to agree on what's minimum. We're actually being all embracing and trying to include all the data elements that are useful. And in fact, we can often get consensus quite easily amongst the clinicians when we're trying to get the maximal data set. I think it's easier than trying to do this minimal data set and the bare minimum agreed. We try them once and we then design them so they can be reused in multiple different contexts. So that's part of the beauty of it, and I'll talk to you about some of the practical implications of that with some projects we're doing. The notion, how achievable is it? Up to, say, 10 archetypes would be enough to create an emergency summary that might have enough basic information to be able to save a life, adverse reaction, medication orders, problem lists, etc. And I think that, there's a bit of argument, and there's still certainly a long way to go, but the notion of there being around 1,000 might be certainly close to the number that we might need for covering most of healthcare. So we're thinking of one archetype for every single diagnosis, but we have one diagnosis archetype at the moment. We use terminology linked in that archetype to enable all the diagnoses to be covered. So it's that kind of concept that we're looking at. It's not something that's unachievable or it's going to take 50 years. This is something that could be done with a concerted effort in a reasonable time frame. And we've certainly done a lot of work towards getting the very core content that's reused most for every consultation, for every discharge summary, those sorts of things. A lot of work's been done on those core archetypes already. These archetypes need to be tightly governed, and that's a really important thing. We have a tool called the Clinical Knowledge Manager, which is being used as a repository, but also a place for governance, so we know exactly what's happened to each archetype, and any vendor who starts to use archetypes can know any changes that might have happened if the clinicians recognise that there does need to be some modifications to the archetype or additional data elements, etc. Terminology bindings are largely done, the data element names within the archetype. Templates, on the other hand, these are the use case specific artefacts. So this is much larger. These are representing the messages or the documents, clinical consultation, record, a report, and these are where we aggregate multiple archetypes into one place, and we constrain those maximal data sets down to ones to just the data elements that are relevant for that clinician for that purpose. So the templates are very much use case focused, and they utilise those tightly governed archetypes as the basis for the templates. There's as many archetypes as we need, so there can be anything from 1 through to, I think I've created some templates with about 70 or 80 archetypes. And we use 1 or 2 data elements from each of those archetypes to actually create the use case specification that you need. There's need for governance. Some of the templates that might be used for reporting may need quite a lot of governance, but in fact, if the archetypes govern, then the templates allow for that clinical diversity to be expressed. Terminology that's bound at the template level is usually the value sets and so on that you'd be using from SNOMED. So this is where our list of diagnoses would be linked to an archetype within a template. For example, in a tool that we call the archetype editor of the blood pressure archetype, it's just seeing one part of it, so you've only got 5 data elements, and there's in fact about 40 data elements, I think, within the blood pressure archetype itself. And you'll see there are things around events and the state of the person and the protocol that actually have other data elements that are in context within there. You see that the systolic is highlighted here. It's a quantity. That's what the Q's for. We've got a description of what it is. We've identified that it's a pressure, and the units that we want to express are millimetres of mercury, and we've actually set up a minimum and maximum value. And in fact, we set them up to be 0 to 1,000 here, and a lot of people look at 1,000 millimetres of mercury as the upper limit of systolic blood pressure. And clearly it doesn't make sense, but it does mean that if anyone tries to enter in a 4-digit number into an electronic health record, there will be obviously a validation check that will say it's not valid and won't be allowed. Now, template, we can actually constrain that down for the clinician who's actually active and looking after or describing this particular record or whatever it's being built. They could say we want an absolute maximum level of 450 or something like that, and they can actually constrain it down, so it makes much more sensible reasoning within the template system itself. So looking at the blood pressure archetype within the clinical knowledge manager, so it's exactly the same thing represented or rendered in a slightly different way, and this is very similar way that we get clinicians to actually review the archetypes themselves. Since the similar sorts of things, we've got the systolic here. It's a quantity. We've got the same description again. We've got less than 1,000 millimetres of mercury, etc. So this is the same, exactly the same model, represented a slightly different way. This is another way of looking at within the knowledge manager as well. So we've got a mind map. So again, it's exactly the same thing. You can see more of the data elements there that fit within the state and the protocol, etc. That's the same model, just different views, different ways of looking at it. And I've certainly had clinicians who have no knowledge about electronic health records, no knowledge about OpenEHR itself, but they look at that blood pressure mind map and they've been able to say to me, you're missing this and you're missing that. And when I looked at it, they were absolutely right. And we had people been looking at it for years who haven't actually seen it. So we're trying very hard to find ways to allow clinicians to be able to relate to these kinds of models and to de-technify them as much as possible. Now, it's not completely possible to do that, but certainly we've been able to get clinicians who have very little knowledge about any sort of eHealth or technical side of things being able to contribute to making sure that the models are correct, and that's been really quite exciting to see. Something that Seven's been trying to do for quite a long period of time, and I think Ed Hammond would say, he's found very difficult. So he's been very excited to see this. Now, this is an example of a template, and this is another tool that we call as template design, and this is where we've actually got an aggregation of templates, and the purpose is a teleotology assessment. So this is some work that I've been doing in the Northern Territory around hearing health with the remote Aboriginal children. It's a program to sort of to track eHealth and making sure that we can know what things need to be done for the kids. And one of the ways they do it with 3 ENT surgeons in the Northern Territory is that they get nurses to go out to the remote communities and they actually record some things and then send it back to the ENT surgeons who are within Darwin or Alice Springs, and this is part of the record. So each of bold black headings here is an archetype. So you can see this is an archetype, and this is an archetype, and these are the data elements within it. Now, this is actually an archetype called examination of external auditory canal and tympanic membrane. It's a hugely long name. It's probably the longest one we've got, and it's been renamed for the purposes of these clinicians. What we've also, you can see here, where these are black, these are actually exposed for this particular use case. But these ones here have been grayed out, and that means we don't actually want them active in this particular use case. So this is the way that we start to constrain them down, and we only allow the black ones to be active for this particular teleotology assessment. That's the clinicians have asked for.
Hey there.
This is the...
Hello?
Yes.
Hey there. Before we move on to the latter parts of your slide, I have this interesting question from Archetype. I hope you would stay around 3 minutes to accommodate this question about the difference of HR model, reference model, and AL7 RIN. For I will use the IT team to ask this to you directly. So, hello?
Hello.
Hello.
There I am going to, the person you're hearing is, I think, Dr. Bunchai, our co-chair for the eHealth Information Network. Go ahead, Dr. Bunchai.
Hello. May I ask, could you compare and contrast AL7 LIMS and OpenEHR reference model?
That's a thing that really is not something I'm comfortable to do because it is quite technical. Certainly, they're similar at a level that there is a reference model, but the version of the AL7 largely is around the messaging paradigm, and OpenEHR is about the full electronic health record. I think to really do that justice, it would be getting one of my technical colleagues on who would be able to speak to that at great depth. But as I'm a clinician and I really stay very much in the clinician space, I'm sorry not to be able to do your question justice, but I would hate to mislead you with that either.
Oh, thank you.
I'm sorry about that. There's some slides that I would be able to send to you that do show the difference between it, but I honestly don't feel qualified to be able to give you a proper answer.
Okay, it will be great. Thank you. Okay.
You wanted to ask a question, is that right?
I think you can go ahead. Thank you very much, Dr. Bunchai. Sir, I have another question here from JS. I'll ask if he there. I will unmute JS. J is from the Philippines. J. Okay, his question is, how much is the software she's using for OpenEHR cost much? Patient issues, technology transfer conditions, and training costs of OpenEHR.
Back here. This here is a type editor, and this is open source, and it's available from the Open Source Foundation for a download. There's also another one that's called Link EHR. That's another open source archetype editor that's also available. The here is an open informatics tool, and that is available for free. So I can certainly supply you with the download and the opportunity to be able to get access to that. The Clinical Knowledge Manager itself is also a tool that Ocean has been involved in developing, but that is something that is under license, and we are certainly happy to talk to people about doing that. There's an AIM that is available for use for everyone for free, and that's the OpenEHR community. Australia has actually taken an instance of that, and there is a NETA clinical manager as well that they have under license, but they make that available for everybody to be able to look at for free as well, and for users to be able to look at, but they control that environment and the archetypes that are allowed to go in it, etc. There are a number of other groups who are also, from small ones right through to national programs, who are starting to get active in this space, and we're able to sort of support anything from a small research group through to a full national program to be able to utilise these tools. But we would need to speak to you and about what the requirements would be. That's helpful. Training, etc. There is a number of groups internationally who are starting to be able to support people with commercial training, properties, opportunities. Again, I can point you to some of those groups if you're interested.
Okay. Ms. Heather was able to answer your question. So later, I hope I could ask some resources from there so I could send it to you, Jay.
So the next thing I was just going to talk about a little bit was the notion of reuse. So down the middle, you've got a list of archetypes. So we have an issue archetype and a weight archetype, blood pressure, hemoglobin A1C, a fetal heart rate, and an assessment. So you can see a little bit here how in a diabetes checkup you might be able to record some of this data and then use the same archetypes for a slightly different clinical context, but looking at reuse in a different template. So this notion of building the archetypes once and then reusing them, that's actually very powerful. And the thing I wanted to point out and just emphasise is there's quite a clear demarcation within OpenEHR about the technical side of things, so the full electronic health record capability that can be built on the basis of the rest of the specifications is down here at the bottom, and the notion that the clinicians can work in parallel. They can be working on archetypes and the creation of templates, the archetypes within those templates, in parallel to the software development, and then allow the engagement to happen. That way they can actually build these clinical content specifications that the technical engineers can just consume. OpenEHR goes here to the OpenEHR Foundation, so it holds the open source specifications. It's got nearly 20 years of research and implementation experience underpinning those current specifications. It's very much been designed by the engineers to make sure that it's going to work technically at its best and allowing the clinicians to then contribute in a way that isn't available in any other paradigm where they do things best in the archetypes and templates. The international community, I'm actually not sure of the size, but certainly within the OpenEHR Clinical Knowledge Manager community, we have over 1,000 people registered from 72 countries, and that will be just a very small subset of the actual OpenEHR full community that operate on the email lists, etc. So it's been quite exciting to be part of that group. Here we have a community of 1,000 people using one tool who are prepared to start to collaborate on building these models. The next part that I wanted to talk about is something this is the last component, but probably the most exciting bit, I guess, from my point of view, and it's about something that's becoming known as the OpenEHR method or the OpenEHR methodology in some groups, and it's about how we're starting to work with clinicians to put all of this into practice and how actually starting to make this work. So this is the work that I've been doing with the Northern Territory, which is one of the northern jurisdictions, not a state, but we have states and territory in Australia, and this is up around Darwin. There's a lot of very remote communities who are quite isolated, and they've got quite specific needs. It's very different to what I'm used to as an urban clinician. And so we've been doing some work around hearing health, which I described before. The RMP on call is about remote medical practitioners on call who are based in Darwin, Alice Springs, who are helping organise retrievals for very sick patients using the Flying Doctor Service or Care Flight and similar kinds of organisations, bringing them back to tertiary hospitals when they need major care. And we're trying to build a system for them that will help them to manage that triage. And so what we did, we brought some of these clinicians in from their remote communities, and obviously their time is very important. And we brought them into Darwin, and we had 2 days with them, and we spent time just going through gathering the clinical requirements. And what I do with them, it tends to be, I do it as a mind map. And because something that they can relate to, it becomes effectively a living document that we can grow and we can move around until they can actually look at it and say, yes, that's exactly what we're doing, and you've got the right level of detail. And also perhaps see if you've got the right screen resolution, we're identifying archetypes that are already available as well. We're looking at what the units might be. We're looking at what the different value sets and so on are. So this is the kind of way that we start to build the requirements. And we're doing actively with the clinicians in the room and approving it. just writing documents and sort of doing it that way and feeding it back to them. But they're very, very engaged in what's going on, and they have a lot of ownership of what the process is. So you can see here that, in fact, that's quite a big mind map, and that's really just based around one aspect of this RMP on Call project. So we spent 2 days, we created these multiple mind maps as this live evolving documentation, identified the templates, and we identified the archetypes that we needed. What we also did was we looked at the workflow, so we captured some photos and we talked very much about what the workflow was going to be and what was required. And we, in parallel, also created templates. As we built the mind maps and we identified the archetypes, we actually created the templates as we went along. And so the clinicians were actually able to say, these are the right archetypes, these are the right data elements, we don't need those ones. We're going to constrain this particular rate with a quantity with particular units or particular limits, etc. And so they were able to actually be very involved in getting those specifications right. And they were doing it on the spot. It wasn't something that was being done over periods of weeks or months. It was actually something that we had a lot of benefit from within a very short period of time. So really, I haven't seen any other ways of getting the clinicians engaged in such a way, and they were really excited by it, and they were really they bought into it. They could participate actively, and it was representing their clinical knowledge. It didn't take them long to understand what this template representation meant. So that's been a very positive thing that we've started to be doing. So you can see there's quite a lot of detail. You can see, again, multiple archetypes here that are the different ones, and here's one that's been opened up with the data elements that's in it. We put all of those archetypes and templates into the Clinical Knowledge Manager. Now, this is a screenshot of the OpenEHR one, so this is the international one. You can see down the side here there's a list of various archetypes that are available, and this is, again, is the blood pressure, so it's the one that we saw before. This one within the international CKM. This one that's within the NETA CKM, so this is the Australian one, but what we're looking at here is not an archetype, it's a template. So we can actually put the templates up there, and this is that template that we were building with the clinicians we've been able to put up onto this website. And again, sorry, here again, we can see more detail as it scrolls up, but that is the breadth of that template, and the clinicians can click on these drop-down boxes. They can see the value sets that we've assigned. They can see some of the constraints and the units and so on. And we're just in the process of being able to organise review rounds that the clinicians can actually give feedback online around the templates. They can do already for archetypes, and just about to complete that block of work to be allow them to be able to do that for the templates as well. So this is output. So this is an XML output that allows the users to be able to take what the clinicians have done and start to utilise it. So this is a template data document. Is one of the common outputs that's been used in OpenEHR. So XML, knowledgeable developers don't need to necessarily know everything about OpenEHR, but they can start to engage as well. So again, we can have people talk to you about this side of things, but that's starting to get into the space that's more technical than I'm comfortable with. But it's in the link between what the clinicians can do without having to understand all of the reference model and all of those kinds of things, but still be able to contribute to this process actively. At that project, we actually sort of analysed all of the archetypes in the templates. We found that 16 of the archetypes we required, 50% were reused directly without any changes. We applied some, we applied about 3 of them, which 59% of the archetypes we used were able to be reused, which is quite phenomenal. So it was very quick to actually build, a large proportion of our templates, and we had to build 13 new archetypes. So in fact, I'm working on some antenatal work at the moment, and really, I'd say we've probably got about 85% is reuse. And we're building about only a small proportion, 10 to 15% of the archetypes we're having to build new for this particular project. And every project we come to, we're actually finding that we're able to reuse more and more of those ones that have been created for earlier projects if they've been designed with this notion of the maximal data set and the universal use case in mind. So that's actually very exciting to see. It's quite sustainable. And this is another last, sorry.
Just to interrupt you for a while, there's another question from the citing from
Please.
Dr. Bunchai regarding the census. You're doing. Dr. Chai, go ahead for your question.
Yeah, thank you. I'm not quite about the archetype, but my question is about template archetype and HR7 CDA. Are they complement to each other, or it be used together, or it should be used each? I mean, we have to select one of those.
The archetypes and the templates are about the content, and there's much complementarity, so that there's been discussions around this of archetypes being the structured content within HL7 version 2 or in a CDA document. In fact, in Australia, in the PCEHR, the Person-Controlled Electronic Health Record, archetypes are the basis for all of the PCEHR specifications which are in CDA. So certainly, if you want to get into atomized data within the CDA, the notion of using archetypes would make a lot of sense, and that's really what NIST started to do. Although, I mean, they're not endorsing the use of OpenEHR as such, but they've certainly used this OpenEHR methodology as the basis for these CDA specifications. When we spoke to Hammond from HL7 and we've spoken to some of the CDA people, they can certainly see that there is some synergies here, and it would make sense. We're very good at OpenEHR with this sort of clinical content standardization. There is a very good possibility that this could be done. So certainly it's happening in Australia. The HL7 International would adopt that. I don't know. There's a lot of politics. The V3 people would say that we're doing this as well, but I think there's a lot of problems within the V3 world that are being experienced, a lot of pain, and I'm not sure whether that's something that is going to be sustainable in the future. Certainly from an OpenEHR point of view, we would be very happy to collaborate for that to happen. That would be very exciting, I think, and that means that HL7 and OpenEHR are actually doing things that they're both expert at and collaborating for something that would be of benefit to everybody. Answer your question?
Yes, quite. Thank you. And another question is that does the OpenEHR template equivalent or similar to the CCD, the ECD clinical document, which is contained by CDA?
Work to look at how we could actually represent the CCD document in a template. So there's certainly that we could do it. It hasn't been used, to my knowledge, in that kind of context, and I certainly know that there are people in New Zealand who are very interested in doing that as well. I've done some work, I guess, to look at how we might map that across. So yeah, I think the answer is probably yes, but no one's actually formalised it as such.
Okay, thank you much.
Thank you. We're nearly at the end of my slides, and I'm conscious of time. This slide is really, again, just trying to emphasise this notion of reuse, and again, using this Northern Territory example across a number of these projects. Across the top, a number of the basic documents. So we've got shared antenatal record, an audiologist consultation, an ENT consultation, here we've an operation report, and so on. And you can see these numbers here, others of archetypes that are used within each of these templates. So here's one that's got 57 archetypes, and you can see that 4 of them are this common healthcare service request, and 3 are about anatomical location, and 5 are around symptom, and so on. So you can see the makeup. But here down this line here, with each of these archetypes that I mentioned, across all of these templates, the healthcare service request archetype is actually used 33 times. And here's this one used 23 times, and symptom used 19 times. So that's just emphasising this reuse. So if you get this model and build it well, you can reuse it in all sorts of contexts. So we're looking at consultation notes, we're looking at reports here. There's all sorts of ways that it can be used. So that really underpins this notion of OpenEHR. And the message is it's all about the data. And what I like to urge you is to the viewpoint that we've kind of all grown up with over the years and we've become used to. Let's think of the data as a health record rather than an application or a message or something like that. The data, that universal health record, that's what I mean by the UHR. This is what's actually important about freeing up that data, breaking it down that it's not bundled up in a silo related to an application or a particular technology or a particular vendor. And that actually sort of turns this whole eHealth ecosystem on its ear. You know, turns it upside down. Enables us to have health information actively being shared. It enables us to have this health record that we can take from cradle to grave potentially. You know, there's other steps in along the way, but data to be transparent and openly shared and specified goes a long way to making that happen. And what we're doing is we're making this clinician-driven for the first time. We're enabling that clinical variability to be expressed even though we've got really tightly governed archetypes, and that's a really important concept. Those building blocks are governed, but then the clinicians can express whatever they need to do with their patients and how they want to record it, still using those templates. It gives them that freedom, and it's about this sustainable reuse that we haven't had before. So I guess the key messages I'd like to leave you with, there's some of the URLs of the OpenEHR Foundation itself at the top, and 2 clinical knowledge managers that you might like to look at in the future as well. That's really what I plan to leave the presentation, leave it for any questions that you might have. Thank you very much for taking the time to listen. Appreciate it. I hope for a little bit of my excitement.
Thank you very much, Heather. This is Dr. Alvin Marcelo, our chair. Some short message before we end. And also another request from the site team that you have the archetype concept. But let's go ahead, Dr. Alvin.
I'm not closing the session. First, thank you, Heather, for us an overview of OpenEHR. Asia eHealth Information Network is a loose network of informal and formal eHealth advocates in at least 9 countries in Asia. When I formal, these are official government representatives who have been mandated to develop the eHealth strategy of the country. And when the informal networks, these are the academe, private sector, and non-government organizations also interested in the eHealth of their country. We the network to catalyze the collaboration and the multi-sectoral approach to eHealth development. And we've been inviting resource persons to talk about their projects. And the OpenEHR idea was raised in one of the meetings. My question, and if it's okay, is
Please. Yes,
yes.
please.
So I think Dr. Bunchai from Thailand, he's part of the formal network. Already questioned about OpenEHR and HL7, and you did say that it's better didn't speak about OpenEHR, but not really official HL7. So I understand that. An article that the CDA, there is an intersection in the XML format of OpenEHR and the HL7 CA version 2. So I'll try to get that article out and share it with everyone in this talk. That might clarify if there is indeed an overlap between OpenEHR and HL7, which means at some point they might actually coexist.
There's been some work in Australia developing a standard. I'm not sure if it actually got published around the use of archetypes within version 2. I think there was some internal politics that got in the way. I'm not sure if it actually got finalised, but certainly there's been quite a lot of work done with that. I know that our company has had experience in generating CA directly from archetypes. It's not a straightforward process, but certainly it can be done. And I know that groups like NETA are utilising it as the basis for CDA development. So you actually are getting that standardised, atomised content within the CDA document.
So fundamentally, Heather, OpenEHR creates XML documents. Sorry, it basically constrains the documents that store patient data, right?
The language that is used is Archetype definition language, and we do have transformations into XML so that we don't have to have people utilizing or fully knowledgeable about the itself, so you can be OpenEHR agnostic and just know XML if you like. So there are a number of transforms and outputs from the archetypes and templates.
Right. Experience. We've been doing electronic medical records since 2005, and that found out that applications and software get old very fast.
Yeah.
And 2 to 3 years after software is created, you have to like everything again on a new platform. You know, when the components get upgraded, then you start upgrading everything else, and everything gets broken down right after that. Maybe an XML type of persistence mechanism with the EHRs greater flexibility, because you've now separated which are the real important stuff, the applications, which are the management of the data thing. I was sharing our experience with OpenMRS concept dictionary, and very simple the way concepts are defined in OpenMRS. Today, you are more formally defining concepts / archetypes in OpenEHR. Do you think there's a possibility of like OpenMRS concept dictionary to an OpenEHR archetype repository?
To explore that further, I did go and speak to WHO at one stage. It was about 2 years ago, I think now, and part of the discussion that Patrick Witter at the time was trying to engage with was, could we start to develop standardized summaries, for example, that could be XML output that could be utilized within OpenMRS. And he's also very interested to see if we could start to standardize some of those data dictionaries, because as I understand it, the OpenMRS dictionaries are largely locally developed, and so there isn't a lot of standardization. I'm sure the dialogue could happen. We could start to look at that. I think we had some discussions with a few people within OpenMRS, and that was, I guess, part of the conversation, whether that would work or not, but we haven't been able to continue those. So we're certainly open to have those conversations. I think they would be very complementary. I've divided up that, I guess, I'm not sure whether it really is applicable to what you're saying. I think there was a sense there is that this is the sort of follow-up slide from our client in the Netherlands. So we're saying conversion to conversion, but where he started to use the OpenEHR data, now whether it's in XML format or whatever, however it's persisted, doesn't particularly matter. It does mean that he can plug in a number of applications that are archetype enabled or archetype knowledgeable, if you like. Yeah. And instead of having to change the whole database, the data persists in the database, but you can plug and play whatever applications you want. So if the nursing system needs to be updated, you can, without taking the data or transforming the data, you can just put a new system in that will be able to read the archetype data automatically. So it's part of the beauty of it, is that data then persists. So he saw that there was no more conversion. So this was the way he was communicating to his clients and his clinicians as to what change would be. And I think that's quite an important notion, that it changes the dynamics, I guess, of what we've been trying to live with previously.
Yeah, it's a very beautiful and elegant concept, actually. One before I pass it on to Dr. Bunchai in Thailand again, and to the other participants, is you about the clinical knowledge manager, and you showed us some slides briefly. It's a rated system, so I suppose there will be costs maintaining it. So what's your model for the CKM? Is it a licensing or a subscription model, in case anyone is interested in using it? Over.
We have a licensing model. We're trying to be very pragmatic about that. The OpenEHR one is standalone, and it's for the community. The NETA is one that's designed to be a national library, if you like, and they want it to be authoritative, so they have management of it. We're just in the process of getting a number of smaller groups there's a group in Norway and a group in Brazil who are not quite ready to take it on at a national level, but they are willing to start to do this work collaboratively within particular clinical or vendor communities, in fact. And so we can potentially put a number of sub-domains together where we can actually start to get groups in the same language working on archetypes together. So the Norwegian instance can potentially have other Norwegian groups start to go in, and they can cooperate or not with that other group, and potentially that could grow into a national repository itself, depending on how coordinated they are. So it really depends on what the requirements are. It is an ocean tool that's taken a lot of work, and we would like to be able to open source it if we found the right financial model to underpin that. But at the moment we are having to sell it as licenses. But we're trying to be very realistic and pragmatic too, and allow people to start to use it at small levels. So the licensing is based on the number of assets, which is the number of archetypes and the number of templates and so on. And the pricing is based on that. So it's really kind of user pays, if you like. Very happy to discuss one's requirements around that. We're certainly trying to be very pragmatic about it, because it's obviously in everyone's interest if we can to share this kind of method of working. People are then able to take the international models, utilise them locally, and also potentially send them back to the international community when they've been refined. So it's very much an active collaboration notion that sits behind it. Sorry.
Thanks, Heather. I'll come back after that.
Oh yeah, I have one question. Actually, about archetype for many years, but it seemed to me that the concept of archetype is very difficult to understand. Could you recap or could you explain us again about the concept of the archetype? We are familiar with like data type or kind of template, something like that. But when it's going to archetype, it's kind of not familiar. Thank you. Over to you.
Thank you. Archetype is a bit like think of it as a building block, and it's about one specific clinical concept. So it's the only sort of time when we're looking at a template, we're thinking in terms of kind of document or a report or a message or something like that. And we're trying to break that down into its component concepts, if you like. So when we looked at, let me just see if I can find one of those slides for, we were at the blood pressure, for example. Sorry, I'm looking, and if we look at that, an antenatal record is going to have a whole lot of things in it. It's going to have a blood pressure, and it's going to have the examination of the fetus and the examination of the size of the womb, and it's going to have weight, and it's going to have height, and it's going to have all sorts of things in it. So each of those individual components is represented as an archetype. In fact, if you like, I could show you the clinical knowledge manager. Would that be something people are interested in? That might, because we can actually see archetypes for real. And is that a good idea?
Please, Heather. Okay. It might help. Yes. Go.
So you can see my screen here. This is the OpenEHR Knowledge Manager, and if we can see the number of projects in here, let's have a look at them. So here are archetypes. There are the different classes of archetypes, so there's different ones for different purposes. And the main ones where the clinical content is are here. I'm not sure why it's opening up like this, it's making it a bit difficult. The main ones are observations. So observations are archetypes around the things that we can touch, feel and measure, if you like. So if we have a look at this list, it should make sense. There is an APGAR score. There is blood pressure, there's a blood gas assessment, a blood glucose, there's a blood matching archetype, body surface area, body mass index, and body temperature. So let's have a look at the body temperature archetype. So I've just double-clicked on that. Is showing us all of the things around this particular not how we're recording a body temperature. So we've got a whole lot of things at the front here that are about metadata effectively. So it's about the concepts, the description, the purpose, the use and the misuse, etc. And the data itself, there's only a data element that's a quantity, and it's a temp. So here's your data types. This is data element here, and then a number of data elements around one concept is what an archetype is. It's got a description, it's got the units, we've got Celsius and Fahrenheit here with some limited decimal places. We've got some information about the state of the patient at the time that temperature was being recorded, so we can say whether they were naked or whether they had a lot of clothing on. We can start to get into environmental conditions or whether they're on a treadmill at the time. If you know about the state of the menstrual cycle, so if you're actually measuring temperature and looking at to try and conceive, then you could be starting to document as well. So these things here are where we can see other little archetypes in that actually record exertion or menstrual cycle or environmental conditions once, and we can actually start to reuse them inside other archetypes and nest them, if you like. But continuing with this notion of what is body temperature, there's a how did you measure it? So the protocol is about the method that it was measured. So here is the places where we can, the body sites where it could be measured. Here is the device that could be used, and again, there's a little slot here that we could slot in the device archetype that we've got. In a template, we would put that inside so we could actually say this is the actual machine that was used to record the temperature, if that was relevant. And then potentially any events. So sometimes things like APGAR score, we'd actually record specific times because the APGAR is a mention of how well a baby is doing at 1 minute, 3 minutes, and 5 minutes immediately after birth, and we didn't want it at any vague time. We actually want to be very specific that the APGAR score is very specific times. So this is about one whole concept, if you like, and then we build a template. The template comprises of one or anything up to 70 or 80 archetypes in some instances, but it may only be 1 or 2 data elements within each. So I think we probably have some templates here. There's a demonstration one here about e-referral. This is where the document notion, all the archetypes are in this knowledge manager. It's a library, if you like, and what we're able to start seeing is these are the specific archetypes with the blue. So this is about a referral request. And within it, we've got all of these data elements, the data types. And I think I scroll down, it looks like that's, oh no, there's some other, these are other archetypes down here. So we do have a number of archetypes in here. The PRIM archetype has about probably 25 or 30 data elements, but the ones that the clinicians here have chosen to expose for this purpose is only 3. So the kind of way that they work together. Does that make sense? Is that full? The other thing I can actually show you how we might build a template. So this is this template designer that we were just looking at before. The archetypes are here on this left-hand side. You can see actually in the middle of building antenatal templates at the moment. What we can do is start to make building blocks and we drag and drop them across. So an antenatal summary, for example, drag that archetype across, and it's a composition, so it's a bit like a blank to paper. In a paper record, it's a heading, if you like, that allows us to query for any antenatal summaries. Well, here's a pregnancy health record that I've created before. I know what's in there. It's like the Word document headings, if you like. So this is just headings for navigation for me. And then each of these blue things, these are called slots where we can start to build the other archetypes in there. So I know that if I right-click on this adverse reactions one, I can drop in the adverse reaction archetype. So I just highlight that. Suddenly is all our adverse reaction archetype in all its completeness. Add in family history, here's family history one, and here's our problem diagnosis archetype. And you can see we're gradually, with only a few clicks, really starting to build up quite a complex document. And each of these ones, right, this is the reaction one. All of those data elements, all it's black at the moment, so it's all exposed. But if I don't want certainty, right-click it and I set it to 0 occurrence, which turns it into a grey and effectively means I don't want that in my use case. So I can turn off, if you like, all the things that are too much detail for my clinicians. Actually add again more archetypes in there. This is part of this notion. So this is our anatomical location archetype that I've slotted in there. And I can turn some of those off, so I just keep it to the ones that are relevant. So this is the way we aggregate the archetypes together for a particular purpose, which is an antenatal summary in this case. We do all of these data elements here. That one hasn't actually got it set in the archetype, so we can look for a health education archetype. And here it is, so we drag it across and we add in that way. So that's the alternative way of doing it. So you can see we're reusing all of these archetypes here and just creating them for a different use case. Yes.
So the process is you go on Archetype repository and see if your archetype is already there. If you create an archetype using the archetype editor. So now have a set of archetypes. Then define your template, which is like a composition of like a discharge summary or an antenatal report or morbidity report. And then you get from archetypes what you need for your template and put them inside the template. What happens after you've completed your template?
Then take it. That's well. Okay. So there are ways to be able to
defining the content.
Exactly. So all these ways of exporting it, and my technical team will take them as technical data schemas and technical data objects. We can display it as operational templates, etc., and I can share it as these file sets. We've got ways of expressing it, so bringing it in different ways so other people can use it. But largely, these are the ways that our technical people will take all of that. Clinicians do this bit, and they'd have to understand the reference model because the tools basically embrace all of the rules of the reference model. It allows the clinicians to actively say, yes, turn the data element on, turn this one off, rename this to the reaction itself, because my clinicians use that word rather than manifestation, etc. So you can configure it to be exactly what you need for your clinical requirements. Know that the archetypes underneath are tightly governed and they're strong. Yep.
And I think for the people in the audience right now, I think the most common problem we encounter is the communication between the clinicians and the tech people.
Yes.
I think what OpenEHR was trying to do was give the clinicians a tool where they define their concepts amongst themselves, have a consensus, define the archetypes and define templates, pass on to the techies, and the techies embed it into the archetype-aware software.
And you explained it perfectly.
Hence, it's like the clinicians can't refuse anymore whatever the techies are producing because the concepts were defined by the clinicians in the first place. It's not the same way that we're doing right now. We're doing an OpenMRS implementation. There's a lot of hard coding between the clinical concept and it appears inside OpenMRS. And there's a lot of pooling and arguments because that hard coding gets very, very tenuous later on. And when you have a lot of these hard codes into your application, your ability to upgrade later on becomes a difficult decision. Yep. That's my perspective.
Changing the dynamic enormously.
Right.
And definition too. Yes, yeah. And that's why I did show that sort of methodology. What we did,
right.
The remote medical practitioner work in that 2-day workshop, really the Department of Health were suggesting that they expected that to take about 3 or 4 months, what we did in 2 days. What is clinicians engaged? And we've had some work where we've then had other vendors come in and not understand what's happening, and they're saying, we can change the data, we can do this. And I've had clinicians who are quite meek and mild clinicians by day who actually stand up and say, no, we've decided this is the way it is, this is what we want it to be, and you're not representing it correctly. You know, and they got quite cross. So the ownership has actually been quite surprising to me as well. It's been really refreshing, and I think the clinicians have enjoyed that journey. Some are obviously very geeky, and they get right into building the models themselves, because building archetypes that will work as part of a cohesive library requires quite a lot of training. But building templates is not. It's something we can teach people to do in half a day, and really they could start to be building templates as long as we have a small group of core people who are actually actively engaged in building good quality, well-governed archetypes that underpin them. So that's the secret. If you've got a good group of archetypes, basically then you can start to distribute the template development. But, you know, if you build a discharge summary, if you build one very good document, that can be shared and people can start to leverage that and tweak it to be locally appropriate for their particular country, or even down to sort of hospital or even ward or specialist on a ward. They want slightly different data because they're a paediatric surgeon rather than an adult surgeon or whatever it might be. So it allows all of that kind of thing to happen. But clinicians can drive a lot of this, which is quite the exciting bit, I think.
Is it okay? Were you able to get the answer you wanted? Over. Okay. Heather, you mentioned OpenEHR as an EMR that implements archetypes. Did you right?
No, it doesn't at the moment, but we have had discussions would enable that conversation to continue. I'd like for that to be encouraged from our point of view, and I'm not quite sure why and where that stopped. I don't think it was that there was any impediments or any problems. So I think if there was more interest from your organisation that might trigger it, that might be good.
Can you point us to an organization that has taken the template and embedded it into software? Maybe we can invite them to show how they're able to embed it.
Certainly the Northern Territory Department of Health has an out-of-data repository, and I'm working with at the moment on a number of projects where they're taking that and they're doing that. And the Chief Information Officer for the Department of Health has been telling all of the Chief Information Officers at all the other states within Australia about it. He's had a lot of people coming to visit to see the work that they're doing, and I'm sure he would be very happy to talk to your organisation as well if you wanted to hear some of his experience directly.
Okay, good. Okay, I think we've consumed our time. Thank you, Brother Leslie from Ocean Informatics and OpenEHR for sharing her time with us. The interesting work that they're doing, and I see the logic and the principle behind clinicians discuss amongst themselves first before passing on the concepts to the IT people. I think there's value in that. So, on behalf of the eHealth Information Network and Dr. Bunchai from Thailand and all the other members, thank you very much. Aliyah?
Thank you very much for having me.
Thank you, sir.
Thank you.
Yeah.
So, thank you so much for a very fruitful discussion. We will see again our AeHIN Hour. So for some implementation, I hope you put in your webcams and we will take a short call off within our meeting room. So I hope you could open your webcam. I don't have a webcam on my machine, but I hope I could screenshot of everyone. There are so many people Thailand.
We have a lot of people. Five.
Nice. And also I will be sending an email that will follow up on you on the attendance of the session and some other resources that we would like to share with you. I will follow up with Heather on the or the comparison between HL796 and OpenEHR. So already, Fatima and Annie don't have their with you on.
Is that working?
is clear. You can continue.
I'm sitting in the dark at the moment.
So ready to start at 5 or 6 p.m. period. So I hope you can give that smile. 1, 2, 3. Let me just check if I got that right.
Sorry, it's an AeHIN tradition.
I think it's very nice. Look forward to having further conversations. Thank you.
Okay, I will offline. Thank you, Heather.
Thank
Good night, everybody.
Bye.
Goodbye.
Thank you, Alia. Alvin. ผมว่าเซมเลเวลกับ HL7 แต่แล้วดูงงๆช่วยอธิบายนิดนึงอาจารย์หายกลัวเราจะเข้าใจผิดรู้ไม่หมดArchetype เป็นอะไรนะArchetypeเป็น